Um, Today I'd like to talk about osteoarthritis of the wrist. Let's see, how do I advance this now? There we go. And as you know, osteoarthritis is wear and tear arthritis, and there are several examples of this. These include slack wrist. This is due to ligament injuries, post-traumatic arthritis, which is, for example, following a distal radius fracture, or a degenerative arthritis, which occurs over time. This is so-called arthritis due to the normal aging process. So I'd first like to talk about scapholunate advanced collapse, which is slack wrist. And this is progressive degeneration of the wrist due to resulting from ligament instability. You can have a similar condition of instability due to an ununited scaphoid fracture. This is called scaphoid non-union advanced collapse, or SNAC wrist. Slack wrist was actually popularized, the term slack wrist was popularized by Kirk Watson, who is a hand surgeon in Hartford, Connecticut. And he classified it into various stages. It's a progressive thing. And stage 1 is arthritis between the scaphoid and the radius, a radial styloid. Stage 2 is arthritis between the scaphoid and the entire scaphoid facet of the radius. Stage 3 is arthritis between the capitate and the lunate, so the mid-carpal joint becomes involved. And then stage 4, the mid-carpal joint progresses to arthritis between the triquetrum and the hamate. And finally, stage 5, arthritis between the lunate and the lunate facet of the radius. So the mechanism of injury of this is actually progressive loading of the wrist and extension, which is beyond the physiologic limit of the wrist ligaments. And this is actually a spectrum of injuries, beginning with the scapholunate ligament. This was actually first described by Mayfield and Johnson. And what you see here is what happens. If you look, let's see, here we are. So this is a lateral view of the wrist. And what you see here is the radius. Here's the lunate. The scaphoid is here. And the capitate is here. The trapezoid and trapezium are up here. And what happens is this: the distal pole, or the scaphoid, actually spans both carpal rows. And the distal pole is held up by the ligaments of the STT joint. When you have a forced hyperextension of the wrist going this way, the short radial lunate ligament holds the lunate in position so that it really doesn't move too much, and there's a dorsal force on the scaphoid then that causes rupture of the scapholunate ligament. If this condition progresses, you end up with a complete perilunate dislocation. So first case. I'd like to talk to you about a 50-year-old right-handed male architect who fell while walking his dog and put out his hand to break his fall. So he was seen shortly afterward in a nearby emergency department and was splinted and referred for follow-up. So here we have the x-ray. So any comments about this? What do we see here? So I'm going to add, is Matt Churches on the...
Junior resident.
Yeah, I'm here.
Okay, so what do you see?
So we're looking at an AP of the wrist. Joint spaces look okay. I don't see any obvious fractures. Maybe, I guess since we're talking about it, maybe there's, I don't see any obvious widening of the SL, of the scaphoid and the lunate. And then looking at the DRUJ, it doesn't look obviously wide.
Mm-hmm. Okay, well, the findings are subtle but distinct. I think what you see here is there actually is widening. If you look at the space here and look at the space here, you should have no more than 3 millimeters of space between the lunate and the scaphoid. So it's a subtle finding. This is not a really prominent one, but it's distinct. So you've got widening here. I think that's probably at least 4 millimeters. You have a positive ring sign. It's not the greatest ring sign that you're going to see, but it's there. And if you look here, you see a high scapholunate angle. So this is the lunate, it's tipped up. That's a DC. And if you look at the scaphoid, which is right here, that's tipped down. So you've got probably a 90-degree scapholunate angle there. So going back, you've got the 3 components of a scapholunate ligament injury, positive ring sign. You'll see, I have more examples. You'll see a better example. But this is one that, is subtle, but it's there. Positive ring sign, scapholunate widening, and then high scapholunate angle. And my goal and hope would be that all of you could look at an x-ray of the wrist from across the room and know there's something wrong with it. So many of these injuries are missed in the emergency department, but you should be able to just see these without thinking twice about it. You always look for Galula's lines. The lines, this is the lesser arc here. You can see this is pretty smooth, but if you look here, this looks like it's not quite smooth. There's something going on here anyway, if you look carefully at it. All right, so what are we going to do? I guess, what's the next step?
Matt, sorry to interrupt.
Yeah.
Something else to notice on a lateral that we don't often see.
Let's go to that.
Is you can actually see the scaphoid not only having tilted forward, but it's actually subluxing out dorsally.
Yeah, that's really key, because you can actually feel that on examination. So Jen O'Donnell, what do you think we should do about it?
Hi, so I think given these findings, first I would get some additional imaging, I think.
Yeah, Jen.
As far as treatment options, probably would consider SL ligament reconstruction.
Okay, well, you're right on. So what was done here was
clenched fist view, right, as well? You get that?
Yeah, I'm sorry. We can go back.
You want a clenched fist view?
A clenched fist view would be helpful,
Yeah.
Because you can put a load across the wrist and you can get a widening of the scapholunate joint.
Yeah.
So clenched fist view would have been helpful. MRI is always helpful. I try to get the MRIs if I can. But a lot of what you need to know is right here on the X-ray. And of course, you're always assessing to see that if there's any degenerative change, which would determine what your treatment options were. Okay. So what we did here was a dorsal scapholunate ligament reconstruction using fiber tape. And there are a lot of different ways to do this. I'm not sure, Tony, you might want to comment on this a little. I don't think any of them have been shown to be better than the other. But that's what we did in this case. We had pretty good realignment of the wrist. You can see the scaphoid and the lunate are right together. And the man's pain went away and his motion has been pretty much restored.
Dr. Mason, do you always get an MRI before you undergo surgery?
Yes, I do. I mean, I try to in most all cases. Any comments? Anybody do anything differently? Okay. Next case. This is a 48-year-old.
Comment, Matt?
Yeah.
Hi, this is Nico. So there's different ways to fix this, and I think the problem is in the long term, they all kind of tend to fail.
Yeah.
So I don't think that there's like a gold standard as to the treatment. What I've gotten to this days is I started doing sort of like a 360 reconstruction, where the ligament goes, 360 instead of just dorsal. I'm not sure, like there's no long-term data on that. I don't know if it's gonna, it's gonna hold up with the test of time, but for me, a 360 reconstruction at least makes sense.
Is that like a slab reconstruction?
No, it's, the company that you use has also I use tenodesis screws, and I go from dorsal volar and then wrap it around like 360.
that's, I mean, that sounds pretty sturdy. I guess we'll have to see if that works better than anything else. It always works better if you have a partial tear rather than a complete tear, or a part, you know, if you don't have a lot of the if the dorsal ligament complex is still intact to some degree, and also the age, you know, if you don't have a lot of fixed deformity of the wrist.
Yeah, so I'm not sure if you're going to go into this, but then one thing you also have to consider is when you have, there's a difference between static and dynamic SL widening. Are you going to talk about that, Matt?
No, we're going to actually go on and talk about more wrist arthritis. That's another talk.
Yeah.
I just want.
But basically, the thing about static and dynamic, so if, let's say you get a clenched fist and it opens up, you can't see it on regular x-rays, but you see it on clenched fist. That's a dynamic injury. But then if you have a gap, you have to be careful, because sometimes there's chronic injuries where there's a gap. You may not be able to reduce it intra-op. It may not be reducible.
Yeah. Well, in this case, it worked because we got to the guy right away. You know, it was a fresh injury. And I think, you know, he had some dorsal ligament complex intact yet, so it wasn't completely dissociated. Okay,
Dr.
case.
Masem, did you say that you did, for this, you always do a reconstruction, or did you do a repair?
I did a reconstruction in this case.
Okay, is there like an in like a very acute injury, is there an indication where you can just do a repair, or is that not really done?
Well, I have tried repairs. I've tried a lot of different things, and they don't seem to work awfully well because it's hard to sew the ligament, to be honest. So I've usually, you know, in the older days, I used to use a dorsal capsulodesis on top of a repair. I'd try to repair it with anchors if I needed to. And now I use fiber tape. Nico, you have any thoughts?
I'm sorry, I'm navigating traffic.
Okay, all right. Let's go on to the next case, because we got a lot of cases
so
here.
I have just to make that point. So usually, Will, if the injury is within like 3 to 4 weeks, I think you can try to repair it. But then, if you've ever seen a SL ligament repaired, the way I describe it is like sewing a fart to the breeze. You know, it's actually really, sometimes it's pretty wimpy. And I think in those cases, you should be ready to reconstruct if you don't like your repair.
Yeah, that's a good way to put it.
I've never even seen the SL ligament. I just always nod when you point at it, and I say, "Oh, I see it there," but I'm not sure I've seen it myself. So
yeah, there's not a lot there. It's really short. So, you know, I think it usually warrants a reconstruction. So next case, this is a 48-year-old right-handed male who works as an audiovisual director for a company. And 15 years ago, he was involved in a brawl, injuring his right wrist. He wore a sling for a while, but he received no other treatment for this. He was completely asymptomatic until recently, when he developed radial-sided wrist pain. And this was constant and made worse by pinch and grasp. So here we have it. So let's see. Sarah Stroud, any ideas?
She's post call, so
Oh, okay, she's not
on the
around.
line. Yeah.
How about Fabian?
So this is an AP of a wrist. It looks like there is prior non-union of a scaphoid fracture with associated radial styloid arthritis.
That's pretty much it. I mean, you probably don't need this talk. Yeah, so ununited scaphoid fracture and arthritis here with beaking of the radial styloid, loss of articular cartilage. And here again, you can see the DC, high scapholunate angle. So what do you want to do?
I think you can do like a distal pull of the scaphoid excision and radial styloidectomy.
Yeah, I guess that would work. Usually the approach should be to stabilize the scaphoid, which would be fix it. And then you do a radial styloidectomy to take out the arthritis. I guess with an old non-union like this, you could do a distal pole resection also. That's a good thought. There's not a lot left of the proximal pole. That's the only concern that I would have, but that'd be a thought. So our feeling was this. There we are. Our feeling was, let me get back here. Our feeling was this, the man I felt had a fairly stable non-union, and he didn't want to have anything done with his scaphoid. We were talking about actually fixing it. He was not interested in that. So we went on and did a radial styloidectomy, and this we did arthroscopically. I can show you this.
Dr.
I'm
Mason,
gonna advance through this pretty quickly because it's kind of tedious. You see Dave Roy actually removing the subchondral bone of the radial styloid where the cartilage is worn away. I'm going to advance this up, but what I want to show you is there's a distinct ridge between normal cartilage and subchondral bone where the cartilage is gone. So we're doing this through the 1-2 portal of the radius. Viewing for the 3-4 portal, there you can see the ridge. Hang on. Yeah, there he's right at the edge now. You see that? Right at the edge of good cartilage. And what you want to do is to recess it down about the width of the shaver itself, which is probably, it's a 3.5 millimeter oval-shaped burr, and it's probably 4.5 millimeters in diameter. So that's about the depth that we're recessing this. Getting good bleeding bone. Let's see here. Yeah, there you can see the edge pretty clearly there too. See how deep he's getting it now? Okay, so that's probably all you need to see unless you want to see more. But anyway, so.
Dr. Mason.
Yeah.
Just really quick, for the scaphoid or the scaphoid, did you get a CT at all to confirm healing of the non-union, or did you just kind of?
No, that would have been a good idea. I did not get a CT on it.
I had a question. I thought in a case where you have some DC and wrist instability, you shouldn't resect the distal pole because of the radio scaphoid capitate ligament like inserting there and potentially causing worsening wrist instability if you resect the distal pole.
Well, that's why I was concerned about the amount of proximal pole you have there, because you don't want to take out the radio scaphoid capitate attachment completely. You know, I think there may still be some left, but that is certainly a consideration. But what I wanted to show you here, this is what the resection looks like arthroscopically. So you can see it doesn't look exactly like you did this open, but you've got removal of the subchondral bone, and this is recessed down. So you've recreated a space here, and hopefully you'll have ingrowth of fibrocartilage. Okay, so that's an example of arthritis of just the radial styloid, or part of this, just the radial styloid. Okay, next case, 49-year-old right-handed male automotive technician with bilateral wrist pain. In this case, he had no specific history of trauma, but was very active. He probably had injured his wrist many times, snowboarding, playing baseball, and he also worked as a large engine mechanic, no previous treatment. Okay, so what do we got here? Hunter.
So again, we're looking at an AP of the wrist. You know, we have pretty severe radio scapho arthritis, as well as it looks almost like kind of like subluxation of like the carpus ulnarly.
Yeah. So here you have the entire scaphoid facet is gone. And what about the radiolunate joint, the capitolunate joint?
Yeah, so the capitolunate joint looks like there's some arthritic changes as well. The radiolunate joint looks like there may be some sclerosis on the radial aspect. And then, like I said, it looks like it's almost the lunate is kind of ulnarly deviated off of the radius.
Yeah. Well, it turned out that the cartilage was really pretty good. Here's the interfossal ridge right there. And the cartilage was pretty good on the surface of the radius. And actually I was surprised because it's very hard to tell on the x-ray, but the cartilage on the capitate was really pretty good as well. Okay, so that's, so what would you do? No, I tipped my hand there. Sorry.
Do you get I know some people get an MRI to look at the cartilage and then decide they're going to do a PRC. I usually don't, because it's, for me, I'm not confident in the MRI telling me the 100% status of the cartilage. Do you get an MRI for this?
No, I usually don't. What I do is I just do an interposition if it looks like there's arthritis on the capitate.
Okay. So you take some of the capsule and just fold it down into the base of the capitate?
Yeah, I've done it several ways. I've used Arthroflex or graft jacket as an interposition material. Or I'll just do a capsular flap. If I prefer to use Arthroflex or graft jacket because then I can use a ligament sparing incision and I don't have to destroy the dorsal capsule. If you make a capsular flap, of course, you screw up the capsule a bit. I'm not sure if that's just theoretical or if it really makes any difference, but I would use a capsular flap if I didn't have any interpositional material available or the patient couldn't pay for it or something like that.
So, I mean, the next slide you show a proximal row carpectomy, but why not instead of putting a graft jacket, why not do like a four-corner fusion?
Well, yeah, that could be done. And that's the thing I really wanted to kind of talk about, because you can do either. Let's go back. We did a proximal carpectomy, obviously. So we took out the scaphoid, lunate, and triquetrum. The cartilage here looked pretty good, and so did the cartilage here. So we thought that would be fine. But, sorry. The guy's 49 years old. He didn't want to have a long time of immobilization. And so that was the decision factor. If you wanted to, you could do a four-corner fusion, scaphoid excision, and you'd have the same result. Theoretically, that's better because the lunate fits better in the lunate fossa of the radius. So in a younger person, if this man were 29, I would have recommended that. But in an older person who wants to get going more quickly, I would recommend proximal carpectomy. You know, that the downside of the carpectomy is you end up with arthritis here because the capitate doesn't quite fit. With the four-corner fusion, of course, it takes a long time to heal. Sometimes they don't. There are hardware problems sometimes. And on the average, the ones I've done have gotten stiffer than the proximal carpectomies. You can't move them very quickly, for example.
Aaron, are you online? Aaron,
Yeah.
Kim?
Yep.
Do you know, does age play a factor as to what you can do?
Sorry, the what?
Age.
Yeah.
Does age?
Yeah. So, you know, we do four corner. I think 45 is the age that we think about in PRC, and older than 60. And then it's a pretty big wide range, 45 to 60, that it's kind of a gray area that you can go both ways. I think that, I guess one question I have for Dr. Masem is, I know you want to get him moving faster, but isn't it in the more like active patients that you would prefer a fusion because they're more likely to develop arthritis?
Well, I think the arthritis is a long-term thing, and there have been studies showing that even with arthritis, people aren't necessarily having pain. You know, if you see degenerative changes on X-ray, they're not always painful. So I've had good luck with this operation, and I think the one who has probably had the most experience is Relton McCarroll, who's done, you know, I don't know, 1,000 of them, something, and he's had good results over the long term as well. So I like the operation, but I'd prefer not to do it in a younger person.
One other question. Oh, sorry, go ahead.
So Aaron, so the data that we are, in terms of age, like it's not like a specific cutoff, right? But then we usually look at less than 37. You should probably not do a PRC because they don't do well with PRCs. And so going back to Dr. Masem's point, if this patient was 25, you probably do a 4-corner fusion. After 37, like doesn't mean that, you know, 37 is like this magic number, but then that's usually what I use in terms of cutoff, like around 37.
Okay. One other question I had was in the video, it said that with the PRC, a concurrent radial stylectomy was controversial, but I just wanted to know what's the downside of doing one, and I guess why is it controversial?
I don't know the answer to that one, to tell you the truth, because I've done one. You can see one was done here.
Yeah, I mean, it makes sense to me.
Well, I think, you know, this is not exactly, these bones are not exactly in the same plane as the radial styloid, but I think in certain areas, certain ranges of motion, they're close, at least. And I've done a few without, and patients have had pain where I've actually gone back and arthroscopically removed the styloid, and they did better. So I always do a styloidectomy in conjunction with the PRC.
Aaron, I don't know if it's a contraindication, but you do have to, when you're doing the radial styloidectomy, you do have to be careful not to destabilize the carpus. So that's the key, right? And that's what we teach you when you do just the styloidectomy as well. You don't want to resect too much because you can get into RSC, which is really important for PRC to work. Otherwise, your carpus has nothing to really stabilize it. And then the cavity is just going to drift ulnarly.
Yeah, that's a really good point, because, you know, the RSC goes from there to there, and that's that's holding this from going there. So, because you're taking out the short radial lunate.
Aaron, are you aware, like, what is like the best styloidectomy if you're gonna do one? Transverse, longitudinal, oblique, long oblique, short oblique. You know, how much?
I don't know that. I know it's a very small percent. I think Gelberman has done some studies, 20% or less, something like that. I usually take off just the end, and I take it off transversely.
Yeah. So there was a study that looked at this, and it was actually they came up. It's like a short oblique 3 millimeters. That's what they recommend.
Short oblique would be
like
kind of like this.
No, other way.
Other way. Oh, okay, like that.
Short oblique 3 millimeters. Yeah.
I guess that's kind of what I do. I maybe make it more straight just because it's easier.
I think if you do it arthroscopically, I don't think this applies if you do it arthroscopically. I think it's when you do it open.
I wouldn't do this arthroscopically if I was doing a proximal PRC. So. Okay. So next case. So this is kind of the ultimate slack wrist case. So this is going to be fun for everybody, I think. This is a 48-year-old right-handed male prison guard, and he was working in the prison. He was turning a sticky lock, and I don't know, I've never seen these locks, but I've been told the locks in the prison are huge, and the keys are huge, and the locks are sticky because they're old and rusty. And he felt a pop in his wrist. And then he was referred to a very reputable hand surgeon I happen to know in Sacramento to have this taken care of. And so this is not the greatest x-ray, but tell me what you see here. Anthony Wiggins?
Yep, I'm here. So looking at an AP lateral and oblique shots of the wrist, I can see pretty significant widening of the scapholunate interval, as well as looked at maybe some anchors. I'm not sure if those are in the scaphoid themselves or itself, but yeah. So primarily that significant widening with some subsequent arthritis.
Yeah, exactly. You basically got, these are, I think, generation 1 Mytech anchors. They're the metal anchors that look like little parachutes, and widening the scapholunate interval. So he's had the ligament fixed, but evidently what's happened, it tore out. The ligament it didn't work. Like Nico and I say, it's really hard to do. So you have scapholunate widening, positive ring sign, DC here, high scapholunate angle. What next?
So in the setting of a failed repair, I think it may be reasonable to try a reconstruction for this gentleman of the scapholunate ligament.
Okay. So persistent pain post-op, prolonged rehab, splinting, off work. He still didn't get better. So that's what we did. And this is what I was doing at the time. This was a few years ago. And at that time, I was using a dorsal capsulodesis. So what I did was reduce the scapholunate joint, pin the scapholunate joint, immobilize the mid-carpal joint with a mid-carpal pin. And then what you do is you take a capsular flap, you use the dorsal intercarpal ligament, leave it attached distally to the scaphoid, so that pulls the scaphoid up, and attach it to the lunate. So you have a tether across here that's a pseudo scapholunate ligament. So it looked really good. I felt really good about it. What do you see here? This is after the pins come out.
So the interval still looks a bit wide.
Yeah, better, but it's still not great.
But it's still, yeah, it's still wide.
Okay. So I was kind of demoralized, and the guy wasn't happy. So anyway, yeah, this is called the Bob Szabo described this approach, and it's written up in the hand journal. So we did that. He had persistent pain with any motion or grasp. So what do we do next?
Not totally sure, but potentially a fusion of those two carpal bones, or proximal. I don't know if a proximal carpectomy would be a little bit aggressive for him, but yeah, I'm not exactly sure.
Well, that's what we did. We were aggressive. Scapholunate fusions don't work too, or historically haven't worked too well. It's hard to get the two bones to fuse, and there's a really high non-union rate. So we basically did a proximal carpectomy. Here you can see I was a little more aggressive in taking off the styloid. This is probably too much, but it's still, I mean, it didn't look like there's still enough ligament intact, evidently, that it's okay. Okay, so let's see, what's next?
Do you do a wrist innervation at the same time?
Yeah, so I always do a posterior and anterior interosseous neurectomy at the same time. Okay, so what happened? Post-op proximal carpectomy, persistent pain with motion and grasp. So presumably, I'm not sure why I was having pain. He may have developed arthritis between the capitate and the lunate fossa. I don't know. So what's the next step?
So is the next step, a total wrist fusion?
You're right on. I mean, I couldn't think of a lot else to do, so there you go. So this is, a total wrist fusion with a dorsal plate. And we can talk a little bit about options here for fusion techniques. This is a Synthes plate. I've just used it for a long time. There are other plates. Any other thoughts?
I just wanted to make a comment. There's a recent systematic review that came out looking at conversion after PRC versus four-corner fusion. And the 1-year conversion rate for PRC to total wrist fusion was around, I think, 10%, 10, 15%.
Wow, that's
It's
fairly
actually much
high.
higher than I thought, compared
Yeah,
to
that's
like
that.
compared to like
And
2%
this,
for like four corner fusion. And so I think you did a PRC and he got converted. I mean, he's within that 10% range, you know?
yeah, yeah, that's right. That's high, much higher than I would have guessed too. I didn't know that.
Yeah, exactly. And so, you know, people say PRCs, they all I think we all believe that PRCs, they tend to do well. But I think it was a Mayo, like 18-year retrospective study where they looked at it, and at 10 years, they in their series, I think they had like a 20% conversion. And so
Right.
I always quote it, you know, at 20 years, you know, 20% conversion. But then the systematic review that came out recently with a 10% conversion at, this was from Harvard, I believe, 10% conversion by 1 year. That was a bit surprising for me. So I
That's
usually
pretty,
now
that's pretty
use that
amazing.
information.
That's pretty amazing. Yeah, I have been disappointed with a few of mine where they've gone on and developed arthritis, you know, and just there are some options you could talk about doing a hemiarthroplasty or whatever, but yeah, I think the early problems they had with midcarpal fusions is that they don't heal well, and the hardware was a problem. They had these spider plates or hubcap plates that were prominent and didn't work as well. So it's a harder operation to fuse than it is to do a PRC.
Do any of the attendings do wrist arthroplasty, and like when would you consider that?
I've never done one because there's so many other options. And I guess anybody else?
So I mean, I went to the course to look at it, and I haven't done one. Not a lot of people have done arthroplasties. The indication for arthroplasty, one of the main indications, like this patient would not be indicated for, in my opinion, for arthroplasty. It's more for like the rheumatoids where you have one where you fuse and the other one you do arthroplasty, you know, for like hygiene. I think longevity of the implant is a issue, especially in younger patients. I've spoken to Dr. Brian Adams, who invented one of the arthroplasties, the ones for Integra, and I'm sure he puts it like much better than, he's probably like a high volume arthroplasty guy, so he puts it much better than like I would, but he's used it for laborers as well.
Yeah, I mean, he stretches the indications a lot, but I think the issue is that there are so many other options that we have that work well that you know, you have to really have a good reason to do a total wrist arthroplasty.
Okay.
Okay, next here. So anyway, the man still has dorsal wrist pain, mostly from synovitis. He has, you know, pain around the extensors, the fourth compartment. He's got some crepitation. So what next? Anybody? Anthony, I've been really beating on you for this.
No, that's okay. I mean, I suppose we could try a revision fusion with bone graft.
You know, just think about it though. It's synovitis, see?
Yeah, okay. So you could attempt to scope arthroscopy.
No, it's synovitis of the extensor tendons.
Oh, dorsal wrist synovitis.
When you put a plate on dorsally, you always get a synovitis.
Oh, yeah.
You don't see many dorsal plates anymore. When I was a resident, they did everything dorsally.
So we could remove the plate if that is directly causing the synovitis dorsally. I'm not really sure what our other options are.
That's what we did, and the pain went away. And here you can see our fusion.
Great.
Okay, so
Anthony, say with confidence, even though you're wrong, that you get full credit.
Okay.
Yeah, no, that was spectacular, actually. Okay, next.
Right.
Next case, 78-year-old right-handed retired woman. So now that was all my slack cases. Let me talk about something else. 78-year-old right-handed woman, retired woman with no history of trauma, but with progressive right wrist pain. And this is a woman who had been
looking around, she'd had several other physicians see her. She was kind of preoccupied with remodeling her home, and she was concerned about COVID. She really procrastinated a long time. But the pain got to the point where she just really wanted to have something done. So here's what we have. Tiffany, Lou, tell me what's happening here.
So this is an AP of the wrist. You know, it looks like there is maybe a bit of a ring sign with the scaphoid and maybe some SL widening, perhaps. Or would I compare that to the other joints? She does look a little bit ulnar positive as well. You know, I would, yeah, I'm not sure if that's, you know, like DRUJ widening or whether there might be some impingement. But, you know, I would do a physical exam, see if she's stable at the DRUJ, see if there's any impingement. You know, or maybe even stress it under fluoro, which I'm guessing you may have done.
What about this here?
Yeah, so that's what I was looking at. There looks like there's some widening. There might be an osteophyte coming off the ulna.
That's what I was to comment on. It's a little hard to see, but this is an osteophyte there. She's really tender over the distal radial ulnar joint. Tender right there.
Yeah, I wanted to also point out, just looking at this X-ray, you talked about the ring sign, right, Tiffany?
Mm-hmm.
And then for me, like the lunate is, the lunate looks like a triangle, so which means that it's either flexed or extended, you know?
Right.
So so I'm thinking, looking at this without knowing anything, is that, you know, the scaphoid looks flexed, then I bet you the lunate is probably extended if you have like a SL injury, like a DC. And then also mentioned, I also see the osteophyte on the head of the lunate.
So this is a chronic, long-standing thing. She doesn't really have any good history, but I'll show you the lateral here. And actually, if you look at it, it actually looks like she's in, I think she's in VC.
Yep,
I think that's the scaphoid there. It's a confusing picture. I'm not exactly sure. I think she had some ligament injury some time ago, and this progressively got worse. She's got kind of a low scapholunate angle if you look here, VC. But anyway, she screwed up her ligaments somehow. And let's going back now. So we have to deal with this degenerative change of the radiolunate joint. This doesn't look too bad here. And we've got this to deal with. So what are your options? Any thoughts?
Well, with the instability, I think, you know, and you were saying that this seems to be a chronic injury, right?
Yeah.
So you could consider, you know, maybe reducing, doing like maybe like a reconstruction, like explore and do a reconstruction. I think one of the things you would probably also want to do would be to stabilize the DRUJ.
Well, you might have trouble because, you know, this is arthritic. So if you do much stabilization, you're going to end up with a painful DRUJ.
Yeah, fair. So you could do, you could resect the distal ulna.
You have to do something here, obviously.
Mm-hmm.
Yeah.
Would you do a fusion of the?
Possible.
Fusion.
Possible. You could fuse that. So let me tell you, that's a reasonable thing. Let me show you what we did though.
RSL.
Yeah, you can do an RSL.
Yeah.
Show you what we did. So this is one that actually Lauren and I worked on. We actually did an interpositional arthroplasty on her. So this is the dorsal approach. You see the extensor tendons. We're going in through the third and fourth dorsal compartments. So EPL, and here's the communist tendons. We do anterior posterior interosseous neurectomies. So here we're making this capsular flap. Remember, it's the lunate fossa that's shot, so we need to really resurface that somehow. And we're doing that with this capsular flap here. So then we resect the proximal carpal row. So scaphoid, lunate, and triquetrum all go. Here's the capitate and the hamate. And then sew down the interposition. In this case, it was a proximal flap that we flapped down in. And so this is sitting on that interposition. And then what we did was to essentially do a matched ulnar resection. So what you do is to resect the ulnar head and leave the styloid, which is attached to the TFC. So you don't detach the TFC with this operation. And you interpose soft tissue in here. And then, of course, afterward, you have to repair the retinaculum. Whoops. So that's what it looks like. Repair the retinaculum. And that's what it looks like. So you have the interpositional arthroplasty. This sits a little bit high because there's soft tissue interposed here. And here's the matched ulnar resection. Any thoughts or comments?
That matched ulnar resection. Did you use a tendon interposition there? You know,
No, there was enough soft tissue with the PRC that we could just put soft tissue in there. Ordinarily, you would roll up a tendon and put it in there.
So PRC.
Man, I haven't done this the matched resection, but then would the advantage be that you don't have proximal stump impingement, which is something that you always think about when you do a DERA?
Yeah, I think so. You can actually have impingement between the radius and the elder styloid, due to the pull of the pronator quadratus. But the idea is that TFC stays intact, so you don't have the same instability that you would have otherwise.
I guess why would you not just go ahead and do a DERA?
Well,
you could do either one.
Laura, I'll tell you something. This is interesting too. I wanted to do a DERA because I didn't know it would make any difference in this lady, and Lauren talked me into doing a matched resection. So I thought maybe it was probably okay to do that, so we did it.
So MFB. I mean, I think you could do either one, so that's good. MFB.
Yeah. All right. So, and here you can see the lateral view. All right. So now we're moving on.
Sorry, Dr. Mason, I had a quick question about that. It seems like, especially for that one, you've taken away a whole lot of the joint, the radiocarpal joint surface, and relying on the capitate articulating with the disc radius for your wrist joint. Do you what are the longer term outcomes from this? Does this degenerate pretty quickly, or how does this end up doing?
You mean as far as the radiocarpal joint?
Yeah. It just seems like, I don't know. I guess
my results have been similar to a PRC
Okay.
in terms of longevity. I think eventually they wear out the interposition and they'll develop arthritis between the capitate and the lunate fossa, or she'll become recurrently symptomatic, and then your option would be a fusion, of course. But this lady's 78.
Right. So you don't need keep it long.
We just wanted to basically relieve her pain and get her back to playing pickleball, which is what she really liked to do. She had to explain to me what pickleball was, but I think she can do it.
Awesome. Thanks.
Yeah. Okay. Next one, 48-year-old right-handed woman, professional horse trainer. And this woman fell from a horse when the horse stopped suddenly while galloping. I don't know if you've seen this, but horses can stop on a dime and you can't necessarily. And she came off. And this is a trainer. So she was seen in the emergency department. This was in Davis, and splinted for a minimally displaced fracture. Fracture healed, but she had persistent pain and stiffness. So what's happening? Okay, here's the x-ray that I saw. So Stephen Garcia, what do you think? Stephen there?
Stephen is on call over at the general right now.
Oh, okay. No problem. about Ryan Freshman?
I'm here.
Okay.
So this AP wrist looks like she had a prior radial styloid fracture. Looks like it's partially displaced. It also looks like there's kind of some impaction at the joint surface. You've kind of lost a bit of your inclination there, and the radius, the distal radius itself looks pretty flat as a result of the prior fracture. Otherwise, the carpal bones look relatively maintained. Jalula's lines look maintained. Don't see any obvious distal radial ulnar arthritis.
Yeah, that's the key thing. That the distal radius looks flat, or maybe even dorsally tilted. Let me show you the lateral. So here's the lateral. Here you can kind of see it a little more prominently.
Yeah, definitely.
Not a great X-ray, but
a lot of dorsal tilt.
A lot of dorsal tilt, and you can see a step off actually here. Right there.
Like an impact, basically an impacted distal radius fracture that is dorsally tilted essentially.
Okay. So what do we do?
Yeah, so I think can you go back to the AP for a second? Just
Sure.
looking at that, I think overall, like we were saying, say dorsally angulated, distal, dorsally angulated and impacted, basically distal radius malunion at this point. So my thoughts here is I worry about the quality of her joint surface. In addition to the fact that she's malunited, I worry that her joint surface, she has like a lot of basically like that step off and impaction. So obviously if this is an acute thing, you would fix it, but now that we're chronic, you kind of want to get it, like I was saying, get a better look at what that joint looks like. You could get imaging, or you could just actually just scope it to see what the joint surface looks like, and then I would probably do she needs like an osteotomy or like a malunion revision in order to actually restore her tilt and her inclination if her joint looks okay.
Well, scoping would be a really good option. I didn't do that, but my feeling was that the joint was in pretty bad shape, and I thought even with Materialize, I don't think I could get this to look good, and we couldn't repair the damaged cartilage.
Sure. Well, then if that's the case, then her lunate facet looks like it's probably pretty okay. So your options here are, you could do like a fusion, you could do a partial fusion here, you could do more radical operation would be like to do like a scaphoidectomy and 4-corner fusion. So I don't think that would be the right thing to do. So did you end up doing like maybe an RSL fusion here?
Yeah, exactly. We weren't. That's exactly what we did. We weren't exactly sure what the lunate facet looked like. Badly malunited distal radius fracture, intra-articular. So this is what we did. So basically, radioscapholunate fusion, and this healed up and did well. She's got about 45% of her original motion. Basically, about half of her original motion. What happens is you take out. Each carpal row accounts for about 50% of the motion of the carpus. So if you take out one, you end up with half the motion that you had before.
You don't have to do anything with the distal pole, the scaphoid here, correct? Like I know there's, if you do some fusion, you basically need to take out like you want to take out the distal pole sometimes in order to improve your motion. Mm-hmm. But in this case, it looks like you just fused in situ.
Yeah, we just fused it in situ. Anybody have any thoughts about that?
Plates versus screws. I've seen plates for this as well.
Yeah, that's right. There are a number of different fixation options. You could use plates. You could also use staples. I'm pretty comfortable with these small cannulated screws. These are Med-Artis cannulated screws. So that's what I like to use. But it's a matter of your preference, I think. I don't know if anything works better.
Matt, we're nearing the end of our time, and I see that Josh Gordon has signed on, so we should probably start wrapping up.
Okay. Hang on a second.
Before you say that, I just want to point out to Ryan, I just want to give you kudos for that point that you made about resecting the distal pole. For those who are not quite familiar with this, if you resect the distal pole, you're basically unlinking the proximal row and the distal row. But I think when you do a RSC, radial scaphoid lunate RSL, it's kind of hard to fuse because there's little bones, and so I think the ones I've seen, the distal pole has not been like taken off.
Yeah, that's a good point. I I think it's hard enough just to get these pins in and get it to fuse, to be honest with you.
Yeah, good point. Good point, though, Ryan.
Yeah, it's a very good point. Very good point. Okay, one more case, huh? 56-year-old right-handed male information technology technician. So noticed sharp radial wrist pain lifting a server. He was actually treated, this is interesting, when he was treated conservatively for de Quervain's tenosynovitis for 6 months with no improvement. So let's look. And let's see, Marcus. What do you see here?
Yeah, we got an AP of the wrist here. Trying to look at this systematically. I mean, I think I see, I can't see my mouse cursor. I feel like I see a little fragment between the scapholunate interval there, maybe coming off of the proximal pole of the scaphoid. I can't really quite tell. And I definitely have some sclerosis there at the distal radius as well, making me think that there's been some arthritic changes there. I don't see any other like definite widening or fractures. I think Galula's lines are intact.
Yeah.
Part. So I think there's probably some sort of old SL injury there, and then we've had the radial styloid or the scaphoid styloid like looks closed down there, but it doesn't look as sclerotic actually as like the interaction between more of like the lunate facet and more like I don't know, non-styloid part that interacts with the scaphoid.
What about the ST? Well, she's tender over the STT joint.
Tender over the STT. I mean,
He's tender.
She. I mean, her joint spaces there look a little narrowed. It's I don't know. She looks maybe a tiny bit worn out, but I don't.
Well, usually the joint spaces should be pretty symmetrical, and it's a subtle finding. But here, CMC looks pretty good. You don't see any osteophytes. You can see cartilage. Yeah, you're a little bit. He's got some wear and tear on the wrist for sure. Here's a good cartilage space. Here's a good cartilage space. You really don't see anything there. You should see this should look like this, or this should look like this, I should say, and it doesn't. So it's a subtle finding, but I want all you to be able to see this and recognize it because it's missed. But it is a case of STT arthritis, isolated STT arthritis. So what would you do?
I mean, I would start with non-op options, obviously, and if those were exhausted and so I think she was still having pain, then I think the biggest thing is you gotta do a resection here, and then if you want to do a tendon interposition, that's fine. If you just want to leave like a big scar ball in there, that's fine. I think the data shows that as long as we cut out the diseased portion here, that that should help with pain relief.
Well, the old timers used to do STT fusions. I tried a few, and the patients got incredibly stiff, so I quit doing that. They've also described resecting the distal pole of the scaphoid, which works extremely well, and you do essentially an arthroplasty. That's all you have to do is just resect the distal pole. Nowadays, I'm doing this arthroscopically. So here's what we did. It was an arthroscopic STT arthroplasty. I usually interpose some gel foam material in there, but I don't think you really have to because it's stable. And his pain went away basically, or mostly went away after this operation. Any thoughts or comments? Nothing?
Like, is there any data showing differences between the type of material you use in the basic to do the arthroplasty with like tendon versus the gel foam versus whatever?
No. Well, I just know about the arthroscopic procedures, and we should probably write something up about this. I've talked with Jeff Yao quite a bit, and we used to interpose graft jacket in the CMC. I've done a lot more CMC joints. We used to interpose graft jacket, and then it turned out it didn't make any difference. I've been putting in gel foam lately because it's cheap, and I think it decreases the hematoma formation, and you can tell the patient that you put something in since you took something out. But I don't think you really need to put anything in. But it would be worth studying. I don't know, but it doesn't seem to make any difference.
Okay.
So the last case I have actually is a woman who developed progressive wrist pain. I just wanted to show you this. You can actually get this. This is mid-carpal arthritis. And it exists. It's not very common. And I don't want to intrude on Josh's talk time here. So
you can finish the case if you like. No problem.
Okay. Actually, these are pretty rare. I couldn't find one that I operated on because they're so old, or the ones that I had are so old. So I'm going to operate on this one, but I haven't gotten around to it. So I have no post-op x-rays, but let me know what you would do. Any thoughts?
I mean, they just talk about capitolunate fusion, like the 2-bone fusion, or capitolunohamate 3-bone fusion. Otherwise, maybe a 4-corner, but yeah, I haven't seen too many.
Yeah, I think you want to stabilize the mid-carpal joint somehow. I probably, these days, I think I'd do a capitolunate, maybe a capitolunate scaphoid fusion here. And just take this out here. And I like those little cannulated screws. Again, you could use a dorsal plate. You could use staples. Okay, that's it, guys. That's all I got.
Thanks, Dr. Masem.
Yeah, you're sure welcome.
Thanks, Matt. Thank you so
much. Welcome.
Always.
Thank you.
All right, guys. Great talk from Dr. Masem, and really challenging topic and really challenging problems. It's a pleasure to introduce our next speaker, Josh Gordon. We actually met on an interview trail when I was applying for a hand fellowship second time around. He went to UCLA for medical school, UPenn for residency, went to University of Washington for his hand fellowship, and now works here in San Francisco. Both he and his dad have continued to be involved with you guys. And this is something they do on a voluntary basis, contributing to your education, volunteering their time, and being generous with their experience and sharing with all of you guys. So he's going to talk to you about extensor tendon injuries, which I'm sure he had a lot of experience up in Seattle with during his fellowship. All right, Josh.
That is true. I didn't take so many pictures. They're not, a lot of extensor tendon injuries are just, big open wounds, not as, so I apologize if I don't have the best pictures in the world. I tried to track down some of my old photos. It's really nice to see a lot of the folks here. Obviously, Tony, nice to see you. I think Eric is out there in the audience. Hao Hua, and let's see, who else is here? Tiffany might have been here, but it's nice to see all of you, and thank you for having me. Let me share my screen. Can you all see that?
Yep.
Okay, great. Let me get this. So I'm going to talk to you about extensor tendon injuries today. I'm going to go through this in a way that I think really makes it pretty apparent how to manage them based on understanding the mechanisms and the anatomy. Also, some uncommon wisdom. I think that there's a lot of limitations in the literature base, and when we don't have something to guide us, we end up relying on dogma. And I think that it's really important to recognize when you're relying on dogma. I can't recall how many times in residency, I was or fellowship where I was told to believe something just because. And I think that there's a lot of times to consider that. And dogma can be important. Common wisdom is also very valuable. But I think I'm going to talk about some of the things where I might have subtle disagreements with some dogma. First of all, surgery is simply applied anatomy, and I think that this is case in point when it comes to the extensor the extensor tendons. The system is quite complex, but understanding the anatomy behind it is really key to understanding the pathology and also treating the pathology. So just quickly, I'm going to go through not a lot of anatomy. I know this is case-based, but just so that we have that background and so that we can kind of refer back to it as we go through the cases. So I just drew these this morning, but these are the extensor compartments. One way for the junior residents, I always try to remember it, or when I had to kind of use a mnemonic. You can start out with longus, brevis, longus, brevis, longus, and that gets you almost all the way across, where it's abductor pollicis longus, extensor pollicis brevis, extensor carpi radialis longus, extensor carpi radialis brevis, and then extensor pollicis longus. And then you've just got EIP, EDC, EDM, and ECU. Some of the common conditions that come up on tests, intersection syndrome, decurvains, each compartment has its own associated syndromes. Now, this is probably the more important picture, and I drew this because, a lot of the pictures, such as this one, are kind of hard to see what's going on a little bit, and so I tried to draw it more clearly. I don't know if this is really better, but I think some important things to see are the triangular ligament coming out just before the terminal tendon, the central slip, and the transverse retinacular ligament, and the lateral bands. I think those are all really important structures when you're considering deformity. I'll come back to this picture, which I think will be helpful. Okay, first case. 45-year-old right-hand dominant female. 1 week ago, she tripped while she was cooking in the kitchen. She reached out to catch herself and hit the end of her finger. She felt immediate pain and shortly thereafter noticed an inability to extend her finger at the DIP joint. She presents to clinic having emailed x-rays previously. An exam reveals the inability to extend at the DIP and flex the position of the digit at the DIP. Okay. So can someone describe the pathology for me, like the name and location? What's the mechanism of this, and what else do you notice in the image? Someone just walk me through that. Let me choose somebody here. Heather.
Yeah, so she has a mallet finger, which can be either a soft tissue mallet or a bony mallet. The location of this is the terminal tendon or a piece of the distal phalanx can kind of come off with it in the setting of a bony mallet. Mm-hmm. The mechanism of injury is like forced extension against a flexion moment.
Yeah, that's good.
And I think what I noticed about the image, could you actually go back to the image quickly?
I might flip that though. It would be forced flexion against an extension moment, but you can kind of say it either way. But yes, just to.
Right, forced flexion against an extension moment. Yeah, and then this is maybe maybe more flexion than you sometimes see in a mallet finger. Like it, I don't know. But other things you would look for radiographically are, you know, subluxation of the DIP joint. So often there can be some volar subluxation, especially when there's a bony mallet.
That's really good. The one thing is I also, when I was looking at her, I thought it looked like, you know, although you can't really see it, it looks a little bit like there's some additional deformity. What other deformity might you look for in a patient who has such an injury?
Yeah, I mean, in that picture, she looks like she might have a little bit of a boutonniere's deformity. Is that what you're going for?
What would usually go with a mallet finger? Would it be a boutonniere or?
Sorry, swan neck. I think I'm just getting my names mixed up. Yeah.
It happens. This stuff is really, so I want to just take a little bit of pressure off. This stuff is really confusing. When I see this stuff still, I got to think through the mechanisms, like, you know, where are the lateral bands moving, what's happening, you know, and so I think that's why it's so important to go back to the mechanistic understanding. So when you look here, when you cut, so why does a swan neck deformity happen, right? It's not as easy to explain as the boutonniere. There's you know, it's a little bit, I find it a little bit more tricky to understand. But when you cut the terminal tendon, where it can either be cut just before the insertion or it can be an avulsion fracture, just as Heather mentioned, you know, there's a bony and non-bony type. But what happens is, you can imagine this releases, allowing the central slips to pull medially or to pull centrally, and actually, you know, decrease the distal tension, which actually increases the tension on the central slip. Because you can imagine, if this force is no longer pulling this distally, when these retract, you know, this is going to pull the central slip slightly this way, putting an extension force at the PIP. Does that make sense to everybody? Is there anybody? Yeah, I'm not trying to. Heather, does that make sense?
Yeah, no, that makes a lot of sense.
Okay, so it's really mechanistic. So when you're thinking about the extensor tendon system, just go back to the mechanisms. Like, why is this happening? Now, what happens secondarily? Secondarily, you can get volar plate laxity, where, you know, you think about folding your hand, right? And the reason why we can't go the other way, at least in part, is because we've got these thick volar plates. These basically it's a ligament on the volar side of the finger, and it stops us from extending. Now, as this extension moment goes back, it slowly stretches this out. Now, we'll come back to this concept, but this is something that I think about a lot, the concept of viscoelasticity. Leah, can you explain viscoelasticity at all, or?
Yeah, I think, I don't know if I have a good exact definition for it, but I think tissues can stretch over time and they're elastic, and they go back to their original shape. But at some point, they reach a threshold where they kind of deform permanently.
Yeah.
And then they can no longer elastically go back to their old shape. I think that's what you're talking about with the volar plate. It gets stretched out permanently at some point once it reaches a threshold.
Yeah, that's a good start. I talk to my patients about viscoelasticity a lot because it's really important in rehabilitation. So I'm going to just give you an example that I give my patients when I'm talking to them, and you'll find that some of the most important things you learn in residency are how to talk to patients. So viscoelasticity is best. It's a material property, so every material has its inherent viscoelasticity. The best material to describe viscoelasticity is silly putty. Does everybody know what silly putty is, or am I dating myself here? Can someone at least tell me, is silly putty still, I'm not that much older than you, I don't think.
Oh yeah, we know silly putty.
I know what silly putty is.
All right, good. Okay. So if you take silly putty and you roll it into a ball and you throw it on the ground as hard as you can, it bounces back up and it's still just a ball, right? It doesn't deform at all. But if you place it on the table and let it sit there, it'll turn into a puddle. The property of viscoelasticity, the fundamental thing is that time is more important than the magnitude of the force. You can apply a low load over a long period of time and it's very impactful. Whereas if you apply a really heavy load all of a sudden, it doesn't do much. And as it turns out, every material in the body is relatively viscoelastic, even bone. So this is why, letting things relax sometimes is very helpful. This is why sometimes during a case, as you progress, things open up for you because you've been applying this force over a period of time. You're also doing some dissection, obviously. But this is an important concept surgically. This is an important concept when you're talking about rehab. Slow and steady wins the race. This is why when we stretch, we take our time. Not to belabor that, but I think it's a fundamental thing to consider, and it involves a lot of orthopedics, not just extensor tendons. But in this case, it's a slow and steady force that stretches out the volar plate over time, applied by the central slip. So this is the x-rays that were emailed. You can see here that there is a significant bony fragment. So when is this operative and what procedure would you consider? What are the pitfalls?
Then we're gonna need the x-ray again.
Okay.
Okay.
How about Hunter? Okay, maybe.
So here we have, bony mallet.
Yeah.
I think what I've seen quoted is like 50% involvement of the joint is when you kind of think about operation. I think the more kind of relevant finding though is, subluxation of the joint, which I think you can determine like fluoroscopically, or I guess just on regular x-ray. And then I can't remember what the final question was.
So when is it operative? What procedure would you consider? And what are the pitfalls of this surgery?
Okay.
Or whatever procedure you decide on.
Okay. Yes, I mean, I guess obviously you can either try to fix it or you could, just pin it. I think here, I guess I would probably just pinnis, and try to, and then follow it. I guess the pitfalls to that would be obviously pin site infection and then stiffness.
Yeah, I think that's really good. So I think the two primary things I look at for considering just straightforward, greater than 50% or 50% of the joint surface. I think the actual technical number is 40%, but I look for about half. It's hard to tell perfectly. Full disclosure, I didn't have a picture of the actual deformity in this case, so the picture was of a different patient. I had to combine them, and I've had to do that in a couple cases. But this was. So I agree with you. I think that some people might think, put a screw in it. You really get at risk of letting that fragment fall apart by putting in a screw. So I think that's one of the pitfalls. I think another pitfall is that you got to watch out for any dorsal flap you raise. So here's a dorsal flap raise. You can see the fragment. It's all pretty clear. I used to use this rectangular flap. I actually transitioned to using a curvilinear flap, and kind of an inverted U-shaped flap, which I like better now. But this is perfectly acceptable. Raise a full thickness flap down to the level of the extensor tendon. And I agree with you. I like pinning this. Now this will get into one of the dogma issues, but you have to be careful of that dorsal flap, and that's what they talk about quite a bit when they talk about extending. I find that I can get the lag to completely resolve, whereas if I don't put in very, very subtle but existent hyperextension, I always end up with a little bit of residual lag. So I go a couple degrees past neutral, and this is the result. And this is, this is another result. So this is the one result from that patient. And then this is another result from the same patient. You can see that there's some remodeling in this case. So this was not quite a perfect result, but very reasonable. And I think this patient had an excellent outcome. You're right, it gets stiff, but you know what? You can get DIP motion back. Now, when I have a bony mallet, I mobilize a little bit more quickly. I do 8 weeks, whereas I do 10 with a soft tissue. My rule of thumb in thinking about soft tissue versus bony injuries is that bony injuries take about 6 weeks to heal and gain enough strength to be sufficient, whereas soft tissue injuries usually take about 3 months to fully mature. In this case, I go 2.5 months, and that's usually enough. In some cases, when someone is really particular and I talk to them about it, I will go out to 12 weeks to allow it to mature. The issue here is that as soon as the soft tissue breaks down, you're basically restarting the healing process. It's like applying glue and then breaking something apart. When you try to put it back together, that glue doesn't still work. This is a piece of uncommon wisdom. So I had a 50-year-old discerning executive for a Silicon Valley tech giant, and he presented to clinic with 6 months after a mallet injury and only 15-degree lags. But the patient found it extremely bothersome, and I advised him to do nothing. He said he wasn't okay with this. It was a very challenging patient. But what are you thinking about?
Have you already tried splinting?
Yes, you tried splinting, all done. Yeah, conservative management. You can assume that. I'll get on to the general treatment. Usually we treat these conservatively. I'll talk about that at the end. It's just not as interesting. So what are you thinking about? He failed conservative management. He's got a 15-degree lag. He's 6 months out. This is a chronic mallet. You're not, the wisdom is these don't really fix, right?
Mm-hmm. What do his X-rays look like?
Well, he has normal X-rays. I don't have the pre because it was non-bony though.
Maybe he'd like to see one of your partners.
He could see one of my partners
if he's a challenging patient.
Yeah, no, I agree with that. That's a great point. Yeah, how to manage patients is really critical. I might have actually done that first. I can't recall if he ended up seeing my dad, who's my practice partner. Yeah, I might have sent him to him to intervene, but he still wanted something done. So I was unwilling to do some big reconstruction, but I told him I would be willing to try pinning it in an extended position, and he got what he got. And so I pinned it. And after pinning, I don't have the pin removed, but he had resolution of his lag. So, that's not the, I don't want to say that that this is what I would do. When I'm presenting uncommon wisdom, I would say, these are things that I find, and I don't know that there's been a serious case series of these kind of delayed presentations with pinning, but this was an observation that, I didn't expect him to get better. I basically told him it's not going to work, but we'll do it. And then he got better. And so, sometimes, that's dogmatic. It's not necessarily, fundamentally true. And so, but the common wisdom all day is you don't do surgery on these, right? And, try to treat them conservatively across the board. This is Dr. Nicholas Vetter. He's the chairman of plastic surgery at University of Washington. And he was famous for when you had a mallet finger. I mean, he's famous for many things, but this is one of his common wisdom points that he gave to us. Whenever we had a mallet finger, he'd show his two fingers. I believe it was two index fingers, and he would point them out to you, and both had a little lag, and one had a scar. And he would ask you what the difference was between them, and he would tell you it's the scar. And he had surgery on one, and he had one treated non-operatively, and they were exactly the same. And so, you know, he always treated mallet fingers almost across the board and fairly aggressively non-operatively. And I think that's really the common wisdom and what everyone should try to aim for. Now, this is maybe not common wisdom and something that maybe you shouldn't try at home. But you know, on the AO website, if you go, they'll tell you never to splint the PIP and never to put it in any hyperextension. Now these are fundamentally, you know, true, but the issue here is that this is a way to end up with some residual lag. Now, what I do use, as I mentioned before, very, very subtle hyperextension of the DIP. Not like this image in the AO reference. So this is, oh, sorry. This is too aggressive, but very subtle hyperextension. You have to look at the finger. You have to look at the finger and ensure, I don't know why that's happening, sorry. Should be good. You have to look at the finger and ensure that it doesn't turn white. Okay, so if you look at that dorsal skin, so I use alumifoam, slightly bent, and I use clear tape. And so I'm able to see the skin underneath the tape, and if the skin on the dorsum of the digit turns it all white or doesn't have, you know, really robust perfusion, I take away that hyperextension. So it's something you have to be cautious about, but the dogma that you just can't hyperextend at all, I think leads to a lot of people having unnecessary extensor lag at the end of it. I also hate stack splints. In order to get a stack splint to work, you have to pad it. You know, it allows some motion. They never fit quite right. You know, everyone says, oh, use a stack splint. I hate stack splints. I think they do terribly. Also, I sometimes will splint the PIP for about 1 or 2 weeks. It gets a little bit of stiffness and you have to free it. It's one of the joints with the greatest propensity for stiffness. But if I'm noticing that the person has the propensity to swan, I want to stop that out of the gates. And so I will do a splint that looks somewhat like this for a short period of time. So, you know, there's dogma out there, and you have to watch out for where, you know, people say things with certainty and they don't really know. And I think that's something always to keep in mind when you're thinking about saying, what does the evidence base really say? What is dogma? And you know, where's the room for future discovery and future, you know, there's so many unanswered questions. And I think that's something to keep in mind as you move through residency. All right, case 2. 36-year-old right-hand dominant laborer carrying a heavy load at work. When, as he felt the load slipping, he adjusted his grip and felt pain about the MP joint of the right long finger. He's felt a popping sensation when using his hand since the time of the injury. Exam demonstrates no tenderness about the A1 pulley, and the finger appears to click when moving from extension to flexion, and the extensor tendon appears to shift over the MCP. Marcus, tell me what you're thinking.
Yeah, the injury at the MCP and then the shift of the tendon makes me think of a sagittal band rupture. Though classically, you're not able to fully extend your fingers from a flexed position all the way to an extended position with a sagittal band rupture. I think usually what we say is if we bring your fingers into extension, you can keep them there. But this, like that shifting, sounds like a sagittal band rupture to me there. Yep.
That's very good. So he wasn't completely unstable, but it was shifting. So he had a partial injury. It would continue to bother him. Why do I mention the A1 pulley?
Why did you mention? I'm not sure.
So this can be confused. Someone can walk in the clinic. It's called pseudo triggering, and sometimes you can think this is the A1 pulley, and you'll push on the A1 pulley, and you have to be careful not to misidentify this as a trigger finger. You know, for people who aren't thinking about it, it can happen. If you think about it, it'll never happen to you. So just keep that in mind. Make sure you don't do that. It's a mistake that can occur. Which finger is the most common to have such an injury? Is this abnormal, or his is a long finger?
I think long finger is the most common.
Yeah, it's about 50% of all of them are in the long finger. I don't have pictures of this, but what I'd like you to do is just stop and look down at your own hand. So what I'll do, if it's just shifting a little, if it's not too serious, and this is kind of uncommon wisdom as well. They usually talk about a yoke splint for conservative management or a full extension splint. If it's really unstable, that is definitely what I'll do. But sometimes this can work as well. So what I want you to do, it depends on which side is injured, but you buddy tape to the side away from it. So what I want you to do is look at what happens to the extensor tendon when you pretend you're buddy taping it away from whatever your perceived injury would be. You see how the tendon shifts just a little bit? So if it's a subtle injury, you can buddy tape and you avoid forceful grip. You have to be able to trust your patient, and so it really depends on your relationship. But more commonly, you'll need an extension or a yoke splint, no forcible gripping. Avoid surgery if you can for these. Most of the time, they don't need surgery. Obviously, if it's really unstable and the tendon is just totally floppy, that's not going to work. There are many different procedures for this. They all work pretty well, but it's various slips of the capsule or EDC looped around. I actually like to take a palmaris graft and loop it around. You have to sew it to the same side that's injured, loop it around the tendon, and bring it back. I think it actually works very reliably. It's maybe a little bit closer to how you reconstruct the pulley. You have to obviously be careful that the slip is small enough that it doesn't cause bulky scarring. Rehab, about 4 weeks in full extension after surgery. 6 weeks at 6 weeks you can free the IPs, or actually the 2 weeks up to the 6 weeks free the IPs. And then at 6 weeks go progressive motion. So again, my rule of thumb is consider soft tissue healing at around 3 months and bony healing at about 6 weeks. This is not a sagittal band injury, but it's the best picture I could have of the sagittal band. So you can see right here the sagittal band, and it's still holding that distal portion of the tendon in place there. Okay, case 3.
You more often see that in normal people like that or fighters. I mean, classically, it's like the amateur and professional boxers and fighters and stuff.
Yeah, absolutely. Yeah, when impact at the MP definitely is a more common mechanism. I don't really know how to, I don't know what this guy was doing with his hands when he was carrying this stuff. This also wasn't the worst case. I don't have a lot of cases of sagittal band rupture, which is why my case is not maybe the most ideal and why I don't have a lot of pictures of it. It's not a, I could not do a case series on these right now based on what I've seen in practice. So I don't know why I don't get a lot of them. I've had more pulley ruptures and climbers than I've had sagittal band injuries, which is strange, but true. So yeah, but you're absolutely right. Yes. Okay, case 3, 32-year-old male, intoxicated, fell on a glass bottle. He's not super cooperative. So how can you tell if the extensor tendons are injured if you have an uncooperative patient? Can you tell? Is it something you have to interact with them about, or? Matthew.
Yeah, so I guess you could just observe them, see if you notice any obvious extensor lag as they're sitting there. You could also look in the wound and see if you see tendon and whether or not it's intact versus ruptured.
Yeah.
I guess it depends on how how uncooperative they are.
What about glass injuries? When you say seeing the wound, what do you think about a glass injury?
Yeah, usually you can't see too well into those wounds.
Yeah, and it's always worse than you imagine it, right? Like, you know, glass, it's like the tip of the iceberg, right? Like, if you've got a glass injury, you can be sure that there is a bunch of stuff under there that's injured. It's way worse than you think. And so just keep that in mind. It's always unseen with a glass injury. It's important to consider that. So what do you do? Like, what's your, so the other way you can tell, you can also do tenodesis to some extent. And you're right though, the position of the fingers is a giveaway. So you don't even really need this guy to cooperate. You can watch him move for a few minutes, or not even, usually a few seconds, and you can tell if there are lacerated extensor tendons. But in any case, you know, on this patient, it's likely going to need an exploration when it's glass. And that's what I was getting at with what are you thinking about based on the mechanism of injury. That is common wisdom. So this is the injury. So after opening it up, obviously, but here it's a pretty nice shot. You can see this is the sixth extensor compartment. You basically got 4 and 5 lacerated here, at least in part. And so what is your protocol? Like how would you manage this? Like when you just think about these big lacerations, like like on the dorsum of the hand, how are you thinking you're gonna go through this?
More senior someone. Who's in there?
I would start with exposure, making sure you have enough to visualize the extent of the injury. I think with a lot of these, like you said, Dr. Gordon, it's always worse than you think. Yep. And so if a tendon is, you know, for instance, retracted proximally, you may not be able to find it unless you have that exposure. And yeah, I would start with exposure, debridement, and then start by tagging known structures proximally and distally.
How would you, you know, so like for your juniors, like what are you thinking about for exposure? Like what do you want to consider when you're designing how you're going to open it up to visualize? What do you want to do? I don't know if this is a great example of this, to be honest. I don't think I
not this one.
Yeah, I mean, you want an tensile exposure, so longitudinal, and often these are in pretty haphazard or transverse form. So try to Z it or in a way that you can get an extensile exposure.
Yeah, the two things I consider exactly. So I want to raise flaps. And so I'll either do curvilinear or triangular flap if I can. I usually extend a little, what I would do is like a principle, I'll extend a little bit beyond the laceration, right? So that I make sure my flaps will give me full exposure. And then I'll design the flaps to raise 2 flaps on either end if it was a transverse incision. You always want to consider Langer's lines, right? You're going to scar better if you go with the folds of the skin. And everything else you said is exactly right. Yeah, so the raised triangular flaps or curvilinear flaps, be considerate of Langer's lines, raise full thickness flaps. Caution for dorsal cutaneous branch of the ulnar nerve and the superficial branch of the radial nerve. Tag the structures, clamp them, and test, right? So sometimes this can be a little bit confusing depending on what level of the wrist you're at. Sometimes there's little clues, like, you know, when you're really getting to the wrist proper, underneath the retinaculum, there's nice grooves and it'll fit better and you'll have more of an idea. But it can be challenging. So tag everything, test it, make sure you're connecting the right thing to the right thing, repair sequentially, deep to superficial. And then remember, you got to tension these. It's going to relax over time. So make sure you don't over or under tighten. Check tenodesis when you're done. So here is just, you can see that you can, it's, you know, you're not unlikely, depending on how distal your injury is, to encounter, you know, the injury I showed was a little bit proximal, but do you encounter the dorsal branch of the ulnar nerve or the superficial sensory branch of the radial nerve. The superficial sensory branch of the radial nerve comes out beneath brachioradialis, about 5 centimeters proximal, and arborizes over the dorsal-radial aspect of the hand. So you're quite likely to encounter a nerve branch and be cautious for it. So rehabilitation, start early. So at 3 to 4 days, I have people come back into clinic, and I'll even start tenodesis as long as this does depend somewhat on the quality. Like if it's a shredded tendon, I might adapt this a little bit, but I try to get them moving as soon as possible. I'll have them do tenodesis, and then I'll have them do one joint at a time. What you're doing when you achieve that is you're getting some excursion of the tendon so that it's not sticking to the surrounding tissue, which will improve the final, or I guess the early excursion of the tendon. But you're not stressing it, right? You don't want to make a composite fist and fully stretch those extensors. That would be bad news and really, I think, test your repair. Perhaps it would be okay for some repairs, but I think challenging. And then usually around 4 weeks, I'll get them, so I'll guide the therapy out till then, because I get worried about someone else doing that. And then I'll get them to therapy, composite motion, etc. And that's, I just kind of, I see them back in a while after that because they're usually good. Early gliding is key with good results. Yeah. So some common wisdom. When you're thinking about the special extensors, extensor indices, and the small finger, always on the ulnar side. So if you cut the retinaculum, if you're at the level of the retinaculum, I like to cut it at an angle so that I can repair it. And otherwise it can be tight. And so if you cut it at an angle, you can kind of slide it. And so you have a little bit more room to work with. Leave the EPL out, superficial to the retinaculum, but make sure it's not tethered. And needles can be used to hold the tendons in place. But honestly, with extensor tendons, retraction isn't that common. This is a case of my senior partners.
Real quick.
Yeah.
What's your repair pattern, or what do you use as far as like with sutures? To how do you repair these tendons?
So it depends on how flat the tendon is. So like EPL, I'll always, that always can take a core suture. So I'll try to do like, exactly like I do with a flexor. I'll do core suture, but I'll be honest. Sometimes when the extensor tendons are really flat, you'll just be stuck with doing figure eights. So like, you can do like a modified Kessler or something. If you can get that in, that's what you should try to do, or a box. I think all those work. It tends not to be as, I think, mechanically tested as a flexor tendon repair. And it's also not gliding through the pulley system.
Yeah.
So there's some things that are different about it. So you can do a couple figure eights. I think it depends on the character and quality of the tendon for me personally. But if I can get a core suture, I definitely will.
So zone 6 like that, how many strands are you going for?
If I can do a 4-strand repair, that's what I'll do, and that's what I would do on a flexor too, right? If I'm able to get that.
Okay.
Yeah, I don't do that. In flexors they do 8-strand repairs and stuff, yeah. and some people espouse that. I think in certain situations that's necessary, but I rarely. I haven't had them fail, and so 4 core strands. I don't do an epitendinous stitch because it doesn't need that smooth gliding. That's usually been enough for me.
Okay.
Yeah. So this is I like this picture. So this is a case of my senior partners. So I don't have all of the details on this, but it was a glass injury for sure. Raise the flaps. I like it because you can see all of the compartments. You see EPL coming. you see the fourth compartment, fifth compartment, sixth compartment, and then you see the retinaculum coming across. So it's really this is just amazing anatomy. I don't know that you often get a case that has such amazing anatomy. You can see here all the tendons are severed all the way across, and this is after their repair. Quite nice. So I think that picture really, sometimes a picture is worth 1,000 words. It's way better than looking at this, but this gives you the context where the retinaculum comes over the top, and you can see that it's kind of this band of tissue, and the tendons insert beneath it. It becomes more fibrous as you get more distal. Okay, 55-year-old right-hand dominant male with remote injury to the digit presents with progressive but supple deformity of the right ring finger. Exam, flexible deformity of the PIP, inflection and DIP and extension of the right ring finger. The remainder of the exam is normal. Does someone want to tell me what the diagnosis is and what's going on? What structure initially injured? Let's see. Jen. Oh, wait.
Yes, can you, do you have a photo of it?
Yep.
Yes, so this looks like a injury at the level of the central slip.
Yep. What else is involved now?
I think that also the volar plate is involved.
So we talked about the volar plate when it came to swanning, but this is a boutonniere. That's not as much mechanistically what happens. So
The triangular. Okay.
Sorry.
That's why I realized the triangular ligament. I see the answer now, but
you're absolutely right. No, good job. And I think that so it's this incompetent central slip, and it's the same thing over time because of viscoelasticity. This slowly progresses. So the incompetent central slip, you get attenuation of the triangular ligament, and the lateral band slip volarly, changing the force application across the PIP and DIP joints. So here you can see first you cut the central slip. So what happens when you cut this, right? You slow. You're not having that force pulling up this way, and so it allows these to pull more because it's not taking the force off at the central slip. So then slowly but surely, as that pulls more, the triangular ligament becomes incompetent, and then your lateral bands slip. And it brings the PIP into flexion and the DIP into extension. And here you can see really how that force would happen. The PIP buttonholes, so boutonniere buttonhole, easy to remember that way. And what you can see, right, as the force changes, you're now going to be applying this extension force as this button holds up, and so you're going to get extension, and it's below the axis, so you're going to get flexion, and so you get flexion at the PIP and extension of the DIP. When you think about it mechanistically, it all makes so much sense. So I will try to treat these conservatively. So you splint, you try to splint the PIP in extension and get those lateral bands to pop back up over. You can do that with a flexible deformity. When that doesn't work, I tend to be a believer in the Curtis protocol. It does require a supple joint. So if you don't have a supple joint, it has to be a staged procedure. You have to make the joint supple first so that you can move it, and then you can apply this protocol. But basically, this protocol requires it's Willant before Willant existed, because they required that you be able to ask the patient to move, and it's a sequence of steps. And as soon as they can flex and extend in a normal position, then you're good. I had to use, in order to get the images for this, I had to use a couple cases. So if the person looks different, that's why. But so the first thing you do is cut the retinacular ligament right alongside the lateral band. So basically release that lateral band, allow it to try to come back up top. Now, if you release it and they can flex and extend, you stop there. You're done. You're done. They don't need anything more. If that doesn't work, you suture the lateral bands dorsally. And then if that doesn't work, you tighten the central slip, which can be done through imbrication or repair. Sometimes, it's a bunch of scar tissue, so usually you kind of have to create that flap and then pull it up. And then if that doesn't work, you have to graft. But once you're into grafting, your chances of success are a bit lower. So rehab for this is splinting in extension, leaving the DIPs free for 3 weeks, and keep flexion. Keep them doing flexion in the DIP, which slowly helps align the bands. So I wrote that in a confusing way, but basically you're just continuing to do flexion of the DIP. So this is what the incision might look like. This is the scar ball you'll usually see. You try to identify where that central slip is. It won't be clear, so it's almost like you have to define the planes. You'll cut the lateral band. You'll cut beneath the lateral bands, freeing that up, allowing it to go dorsally. If that doesn't work, you will cut that central slip to imbricate. Here's an example. This is going back one step, but those are the lateral bands free. They've cut that dorsally. They haven't sewn down the lateral bands yet, which is actually what you'd probably do. This is not my case. It's an example that from my partner that I'm using. You can then tack that down. And this is sewing up the lateral bands, which would be step 2. Tacking down that central slip distally. And extension. I didn't get extension on my case. So this is so you can see that they're able to do this now after going through the protocol. So you're done, but this required all of them. So it's not, you went all the way through except for the graft. So we've talked about 4, I think, really helpful cases. We've talked about some common and uncommon wisdom. Remember swan neck deformity associated with mallet finger, operative 50% fracture or subluxation of the joint. Sometimes with conservative treatment, a little hyperextension is okay, but I wouldn't try that with your attendings unless they're into it. And you've got to check that skin. You really can't, I can't emphasize that enough, because if you're going to do that, especially if it's on the borderline of what other people are not doing, you have to watch it carefully. Sagittal band injuries are usually non-operative. Recon has many methods. All of them work. Usually if you have many methods for something, either none of them work or all of them work. In this case, it's pretty reliable. Direct repair is not as reliable. So that is the one thing I'd say. The reason why a lot of the methods are recon is because direct repair can definitely fail in those cases. For wrist injury, go through it algorithmically. It's going to look like a big injury. Just take your time, move through it step by step. No big deal. Just think about it as a process instead of like, what specific procedure am I doing, right? It's more like, a little bit of creative thinking in that way, where you apply a process to kind of a diverse group of pathology, where injury may vary. And boutonniere, I like the Curtis protocol. There's definitely other ways to treat this. Generally non-op. A lot of this stuff is non-op. So, except for maybe the big open injuries, I would go for non-op. I didn't focus as much on kind of simple extensor tendon repairs and dermodesis and all those things, just because they're kind of more bread and butter. And I thought this went through some of the principles in a better way. But maybe if I do it again, if you guys want, I can do it with more of the kind of basic, zones and all of that. I'm guessing you guys know a bit more about that, because those are all test questions, and I don't think teach you kind of principles. and common wisdom is not always wise, right? Dogma, I had an attending when I was using scope in residency that if it wasn't at 3:30 instead of 3:45 on the scope, clock angles, it was all wrong. And that kind of dogma, sometimes sometimes it's very valuable because it gives you a basis from which to understand. So it's important to learn what the dogma is, but also understand it for what it is. Where the evidence base is lacking, that doesn't mean that the person who's, trust your attendings. Obviously, all the attendings at UCSF are amazing, but I think it's important to understand where the evidence base is limited, where, start considering it. You're a human. You're not, I know that sometimes as residents, we feel like we're robots, but you can think through it and use your mind still. Don't fall too victim to that. And I think the most important uncommon wisdom is that you need to remember that you're a human. And they've done studies where they've shown that people with sociopathic tendencies are very successful surgeons. But the reality is what's going to draw your patients to you is your humanity. And you're going to develop a relationship, and your patients will love you for that part of you and for the real part of you, not for the technically gifted part of you. And I'm sure you all have great technical abilities, and you can develop those over time. But if you let go of that human part of yourself, I think you're going to struggle to connect with your patients in a meaningful way. They're going to be less compliant with you, and your patients aren't going to be satisfied. So don't forget, you're a human, and maintain that part of yourself.